Welcome back to the Andromeda's Way. I'm Michealle Gady, and today I'm joined by Elya Prystowsky, Executive Director of the Rural Collaborative, a statewide network of independent rural hospitals in Washington state. Elya is an epidemiologist by training with a doctorate from the University of Washington and a master's from Harvard University. We're talking today about the Rural Health Transformation Program, $50 billion, 5 years, all 50 states. It's the largest federal investment in rural health in a generation, and it landed in the same legislation that slashed more than $900 billion from Medicaid over the next decade, with roughly $137 billion affecting rural communities nationwide. So the promise is real, but so is the tension. Unfortunately, this isn't an abstract policy conversation. Rural hospitals are closing, rural patients are driving further for care. State agencies and health systems are making decisions right now about how to use these federal dollars, and the choices made over the next 12 months could shape rural health outcomes for the next decade. Washington is worth paying close attention to. The state received $181 million in year one funding, and its budget approved early included a 10% set aside for tribal governments, and the state is already in the procurement and hiring process. Other states are watching, and Elya sits at the intersection of all of it. She leads a network of rural hospitals that is one of Washington's central implementation partners, which means she can tell us what this program really is, what it isn't, what Washington chose to prioritize, and what it will take for this investment to transform rural health rather than just delay the next crisis. So, Elya, I'm really glad to have you here with us today. Let's start by learning about you and the Rural Collaborative. So, your training is in epidemiology and population health. So, tell us about the path that led you from that work into leading a statewide network of rural hospitals. What drew you to rural health and to the Rural Collaborative specifically?
Oh, well, thank you so much, Michelle. And I'm so happy to be here. And I love that I get to represent the state of Washington. Uh, so, a little bit about me that helps you understand my journey. I actually was born on the Presidio in San Francisco during the HIV epidemic. And at that time, my dad was a dermatologist at the University of California, San Francisco. And he was one of the researchers that helped make the connection between Kaposi sarcoma and gay men in San Francisco. And I got really interested in it and grew up kind of listening to him talk about it and trying to understand why some people get sick and other people don't. Because as a kid, it just didn't seem to make much sense. Then as I progressed in my career, I really found myself drawn to the fact that the biggest driver of your health is where you live. It's your zip code. And of course, that led me straight to the rural health path. And I have had the honor of being hired to be the executive director of the Rural Collaborative, October 2019, just 6 months before the COVID travel ban was announced. And so, being an epidemiologist and then also working with rural hospitals, I have never been so proud to be surrounded by people with just a tremendous amount of integrity, people who really serve the community and are committed, they're resourceful, they don't ask for trophies or parades. At the end of the day, to celebrate their good deeds, they just do the right thing, and I've never looked back.
That's really great. So, for listeners that are unfamiliar with the Rural Collaborative, can you explain what it is and the problem it was created to solve?
Well, yeah. So the Rural Collaborative was created by rural hospital CEOs back in 2003 so they could have a space to think together and to build strategies together. Now, it started as a pretty loose alliance of only 5 hospitals. In fact, the original name was the Western Washington Rural Healthcare Collaborative, and they formed around a health information technology grant back in the early 2000s. Did not get the grant. To this day, we still have 5 different EHRs, but they found tremendous value in the networking and the CEO to CEO engagement. Fast forward to 2015, TRC incorporated as a nonprofit, this time with 15 rural hospitals. Now, 2026, we are 31 rural hospitals covering 23 counties. and taking care of around 800,000 Washingtonians each year with a net patient revenue of 2.5 billion. So you asked what was the problem that we were created to solve? I don't think they realized it at the time, but because they just liked each other and they liked being around each other. But really, the reason we exist is to make sure rural Washingtonians receive the same high level access to care, the same high quality care that urban Washingtonians receive. And for more than 2 decades now, these rural leaders have connected with purpose and turned that collaboration into very real operational, financial, and clinical gains.
That's great. So let's talk about how this works. So the organization's tagline, so the Rural Collaborative's tagline is independence through interdependence. So what does that mean in practice for a network of member hospitals that, at least on paper, can compete for workforce and contracts and patients? How does that all work together?
Yeah, I mean, sure, there's always going to be some competition, but you get a lot less competition when you get out into rural health systems.
Uh-huh.
And that's really what makes this work. And it's simple. So these rural hospitals are independent and they could either hang together or hang alone. And they have to stick together. And that stickiness is so important that we've used the term that this is a coalition of the wanting. It's not a coalition of the willing.
Hmm.
Collaboration takes energy, it takes effort. You have to commit, you have to show up, you have to be present, you have to respond, you have to follow through. So the CEOs have formed this engine for shared strategy, network level performance, and payer leverage, all while staying independent.
Hmm.
And this has helped each of them operate stronger, negotiate smarter, deliver better outcomes. And on paper, if you look at it just, quantifiably, the average return on investment for our members is 10 to 1,
That's
which is
great.
pretty astronomical.
Hmm.
And just the work we've done with GPOs and revenue cycle and some other big programs and initiatives has really ended up turning into real green dollars for these rural hospitals.
And that's really important, particularly as we're seeing rural hospitals across the country closing at really an alarming rate. In Washington, though, the rural hospital footprint is really held on. So, after 2 decades of the Rural Collaborative's work, what do you see as the organization's biggest contributions? And given what it has made possible here in Washington, what do you think it would take for other states to build something similar?
Well, I don't think the collaborative can take all the credit. Everything you're saying is true, and I could not be happier. The truth is, our state did expand Medicaid in 2012. Our state's insurance exchange worked the first time and has worked for the last 15 years pretty much seamlessly. Washington state has public rural hospitals. So, by the nature of being public, they benefit from tax levies and bonds that
Mhm.
private hospitals or non public hospitals wouldn't be able to avail themselves of. We have a fantastic state office of rural health in our Department of Health. We have a strong hospital association and association of Washington public hospitals. Washington still is one of the, I think, just slightly half of the states in the country use cost-based reimbursement for Medicaid. This is huge in helping hospitals stay open. So these are like tectonic factors that I have no control over, but I think, you know, I like to think that the Rural Collaborative is part of the solution. Our return on investment is great. Our peer-to-peer networking and shared learning is vital. And we have a saying that if one rural hospital closes in Washington, then we all collectively fail. So there's a
Mhm.
shared ownership over maintaining access, even if that's not your own community.
That shared accountability is really important.
Super important.
So let's take a step back and a bigger picture. So the Rural Health Transformation Program is, as we started, at $50 billion over 5 years. It is the largest rural health commitment in a very long time. But it is connected with the significant reduction in Medicaid dollars, in particular, about 137 billion in rural areas across the country lost. Medicaid dollars. So, how do you hold kind of those two realities together when you talk about the Rural Health Transformation Program with your rural hospital leaders?
Well, it's a math problem, Michelle. It's just basic math. And the rural hospital leaders are they're astute. Um, Rural hospitals will see a decrease in Medicaid enrollment, plain and simple. More uninsured means more bad debt. It means more charity care. You add on top of this the provider tax reductions that restricts how states fund Medicaid. That's going to impact Washington. We will see revenue losses and potentially service line closures or reductions. I think we're already seeing this in OB and these maternity deserts that are popping up around the country. There's really no way around this. It's simple math.
Hmm.
And I mean, it makes me sad, but I am proud of how Washington State is really trying to tackle this, looking for every possible way to help people maintain their coverage. But we are not going to be immune. I would not be surprised if we saw some changes to the Washington landscape. We had one hospital just transition to a rural emergency hospital this year. That was our
Hmm.
first one. We'll do everything we can to soften the blow. And I know that our rural leaders across the network of the collaborative are looking at every line of data that they have to see where they could streamline and or expand to get through the worst of what's to come.
So, one of the points I've made in my own writing around the Rural Health Transformation Program is that if states and stakeholders view this program as a Medicaid revenue replacement, that is going to be a problem. So, if they see it as an opportunity to prop up current operations, that's not really going to work. And so, I'm curious how you see it from where you sit. Are you close enough to see how providers are thinking about this? Where is the field landing in terms of a realistic place, or are you starting to see patterns emerging that are worrying you about how hospitals and other stakeholders are viewing the rural health transformation program?
I think everybody got the memo that this does not replace lost Medicaid revenue. It
Good.
does not. It cannot. I mean, math problem first and foremost. And there are a lot of restrictions around the dollars. And the other piece of this that I really struggle with is the word transformation.
Mhm.
And I just find it's overused and people don't really understand what it means anymore. And they want to transform everything. I actually in preparation for this, I looked up the definition of transformation because it's been a minute since I've looked at it. And it means a thorough or dramatic change in the form, appearance, nature, or character in something or someone, often resulting in improvement or a completely new state. It represents an irreversible fundamental shift rather than a temporary change.
Mhm.
Now, here's the problem. I mean, there's a lot of problems. So I would posit that rural hospitals are the last standing bastions of good healthcare in this country. You get the care you need, you get it faster, it's personal, it's close, it's culturally relevant, and rural people love their hospital.
Mhm.
They do not complain. They really like their hospital. And to think we would want to reverse this is troubling. And secondarily, transformation is unachievable with the money on the table. Like if they wanted to transform, they could have done something like say, we will pay all rural hospitals to go on Epic. That would have transformed rural healthcare. But it's not enough money. In the conditions that we're facing, I don't think we're going to see a lot of transformation. And while I'm on my little diatribe uh, about this word, transforming, we've been transforming healthcare for 60 years. I mean, if you go back 60 years, rural healthcare looks completely different. The Hill-Burton Act of 1946 to build the hospitals, swing beds in 1980, 340B in 1992. Critical access hospitals weren't established until 1997. To think that you can give us $50 billion to replace $137 billion and tell us to transform, it's insulting.
It's
And if you define transformation as doing less with more, which is, I think,
what it's starting to mean.
what it's starting to mean. I'm sorry, doing more with less, which is what I
Yeah,
think it's
yeah.
starting to mean. It means to be creative, to be resourceful, maybe be a little bit scrappy.
Mhm.
And to that end, I think I'm very optimistic about what we're going to do with our allotment in Washington state. Work smarter, not harder, leverage where we
Mhm.
can, maintain access to care, get hospitals paid for essential services, go toe to toe with payers that
Mhm.
continually make it harder and harder for us to get paid, roll out technology that makes sense for rurals in the clinical, administrative, and operational space, and train and recruit the next generation of rural healthcare workforce. We could do all of this. I don't know if it's going to meet their definition of transformation. It certainly doesn't meet mine, but it's the right work.
So, kind of building on that, the Rural Health Transformation Program, it's structured as really a performance-based cooperative agreement rather than kind of a block grant to the
Hmm.
states. And so CMS will rescore half of the funding annually. And then the CMS administrator has a lot of broad discretion in terms of what awards look like going forward. And so Washington's first year budget was approved in February. And then, Montana followed shortly thereafter. But there are other states that are still waiting for their budgets to be approved, including California, which is kind of the largest Democratic state in the country. And this is well past the 45-day review period. So, what does this start to tell you about how CMS is managing the program so far? And what does it potentially mean for political risk down the road?
I'm not very politically savvy. I'm more of an operator.
Mm-hmm.
I also am from California, so I really hope they get their money. I think they deserve it. Focusing on Washington, you know, Washington's a blue state and we got our money. I
Right.
think they already have it. I do think it's a testament to our state's governor's office, the healthcare authority, Department of Health, Department of Social Health Services. They really came together and just they made it work.
Mm-hmm.
I understand that CMS is hiring project officers. I hear that Washington's project officer is exceptional. I don't think this is a people problem. I think looking at this program is one thing. I think the folks at CMS are working hard, and I don't envy their jobs right now. I think it's a values problem that we even are here right now.
Mm-hmm.
If we need our lawmakers to value rural Americans, and until they do, you know, I'm not going to blame CMS. I'm going straight to the folks who voted for HR1.
Mm-hmm.
It's created unrealistic timelines and a lot of fear. I'm optimistic, as I said, about Washington State because I know
Mm-hmm.
I know the players here. It's a fantastic team, and if you want to get rural motivated, just tell them they can't do something because
Yeah.
they will just say, "Hold my beer,"
That's
and climb down and show you how to get it done. I wish the best for California. They need it just as badly as the rest of us,
yeah.
but I can't. It's just too much for me to process.
So, what do you think state leaders and rural providers watching from outside of Washington need to understand about how the program, actually works?
I don't think most people actually understand how it works. Truth be told, it's very confusing in the parameters they put around it, and the 50% goes here and 50% goes there, and here's a rubric, and oh, you can't use it for this, and we like tech, but we're still going to cap it. It's really hard to wrap your head around.
Mhm.
I just tell people if you think this will save rural, it will not. It
Mhm.
won't. Only rural can save rural with the support of our representatives and the other Washington in the Washington DC.
Yeah.
This is not a ladder that will help us get out of the hole. It's an opportunity and we're going to take full advantage of that opportunity, but it's going to require a lot of really smart people.
So let's get into more of the details about what Washington has proposed to do. So the state asked for close to $1 billion in funding, and it got 181 million. So that's not a small shortfall. It's kind of a fundamental question about what the program can actually deliver. So, um, what do you think can be done with the $181 million?
Well, fortunately, so long as we spend this $180 million correctly,
Mhm.
we will get another $180 million next year. So it's not quite that big of a shortfall. We didn't get 19 million. I do think that the way that they came up with the scoring rubric for the states, those states with a lot more rurality and a lot
Mhm.
more geographic spread could get more. In fact, some states did get more than 200 million.
They did.
I was so excited that we got 181 million just because the way Washington state is shaped and with the water and we have the peninsula, we got kind of docked because we didn't fit this kind of mold of like Nebraska or Kentucky or Texas, these other states that are a lot of the same issues, but a lot more rural hospitals and a lot more rurality than we had.
Mhm.
So I think 181 million is it's nothing to sneeze at. I mean, I'm pretty excited about it actually. And I know there's a lot of doom and gloom out there, but I think our state's gonna knock this one out of the park, at least according to the parameters that CMS sets out for us.
That's great. So with that 181 million, the state is, at least in this first year, the state is looking at over potentially the 5-year period, 6 initiatives. So hospital innovation focused on AI, cybersecurity, and revenue cycle, a community-based chronic disease prevention, 10% set aside for tribal governments, the technology and data solutions, rural workforce development, and then really importantly, rural behavioral health expansion. So that includes the mobile crisis support and school-based services. So how and why did the state choose these specific initiatives, kind of from your perspective?
So, how did the state choose these initiatives? Well, I think they're obvious. These are the right things. I don't think anybody would argue with any of these. They did a significant amount of stakeholder engagement and listening sessions, request for ideas, transparency. They spoke to me, they spoke to the hospital association, they spoke to a bunch of other kind of segments of the rural healthcare delivery system. I think these are great categories. We are the home of Microsoft. It absolutely makes sense that we should focus on cybersecurity and AI. And, that should not have been a surprise to anyone. There's nothing in the application I'm not in favor of. I just wish we had more time to implement.
Yeah, because these are big.
They're
These are
they're
big.
big and they will take a long time. Like some of our hospitals still aren't on an EHR that is, the bare minimum. So to even think about something like remote patient monitoring or ambient listening, these technologies, it's a stretch. We need time.
Yeah. Yeah. So one of those particular areas, the 10% tribal set aside, that was a clearly a deliberate policy decision made in Washington because it wasn't a CMS requirement. And it's grounded in treaty law and of course acknowledges the role of Indian healthcare in rural Washington. Do you have a sense of how that commitment came together? And what do you think it says to other states in terms of what they need to be thinking about when it comes to advancing equity?
Well, I have very strong opinions about this, and I will say this unequivocally, that this should have been a CMS requirement. I did not know that until you just said that. I think that's just I don't know, I'm kind of speechless. I know the people who kind of wrote this in. I know the, tribal liaisons at the healthcare authority and the governor's office, and I know all of the stuff. They did a bunch of sessions with the tribes, government to government sessions. They do it they do it well. It's in our DNA here. We have, I think, almost 30 tribes in Washington.
I
A
think
lot
it's
of, coastal
39.
Samish fishing tribes out near the water.
Yep.
And I thought it would be more, to be quite honest. I think when I saw this number, I thought that seems a little bit low. And I
Mhm.
think that I'm not alone in that. I think it's a well established truth, at least in the state of Washington, that tribal healthcare is their right as written in their treaties. And we have to be able to deliver. So yeah, our state did a good job, I guess. I don't know about the others. I'm kind of disappointed to hear that it might not be part of the other states' applications.
Yeah. So let's talk about the work of the Rural Collaborative as this rolls out. So, the organization is identified as an important partner in this work. And so, to the extent that you can, because I think you may have procurements out now,
Yeah.
how are you thinking about using the dollars? And how do you think that will impact your members over the next 12 to 18 months?
So how we will use the dollars is to strengthen the network. I mean, at the end of the day, you know, I said if one hospital fails, then we've all failed in our network. So we have two guiding principles to how we use our 5.43 million. The first is to focus on building a stronger network, which means things that we could do jointly through shared services, shared contracts, shared learning, opportunities to really operate as a unified network without being a system.
Mhm.
Other principle is really around equity, which is not all the hospitals are have the same challenges, if you will.
Mhm.
And so it might be that some hospitals need something now or they need more than others need right now. So
Mhm.
it's about raising the average. So you do that by taking the hospitals that are struggling and making sure they get the support they need to be able to thrive. So those are two really important principles that guide our work. I think they're really cool. I'm proud of our board for choosing this path. To that end, we have decided to focus on areas that are mission critical to operations for our hospitals. So that would be revenue cycle management,
Mhm.
shared services and contracts, workforce development, health information technology, and payer contracting. And you are correct. We are doing all of the legwork. We're getting ready for the money to come in. So we're choosing our vendors. We're involving our members in the selection of the vendors so that they are working with consultants, firms, technologies that they helped select. And then we're ready to go. I mean, we have contracts that we're just waiting to sign and start as soon as that money lands. And I think it's going to start pretty soon.
Mhm.
And for some of your more savvy listeners that are kind of leaning in and wondering what exactly we're going to do, how exactly do you spend $5.5 million? And let's be honest, we're going to have to spend that by probably October, just
Mhm.
because of these timelines. You spend it on revenue cycle root cause analysis. You spend it on payer contract compliance and auditing, shared positions like a shared senior director of purchasing or a shared employment lawyer,
Mhm.
rural nurse leadership training, HR compliance and efficiency audits, IT cybersecurity hub, payer scorecard. These are just some examples of how we're going to spend that money.
I look forward to seeing all of that work. That's gonna be really exciting.
I mean, right now it's exhausting, but I think it will be. It is a great problem to have.
Yeah. One of the things I have some concerns about are the opportunities that are available and some of the smaller entities kind of getting missed or left out just because they don't have the infrastructure or the experience, capacity, etc to apply for state grants that might be available, or they'll end up getting kind of crowded out by larger, better resourced entities. How real do you see that as a risk in Washington? And what's your organization doing to kind of prevent some of that?
Well, it's a real issue. Rural hospitals, often the same person who's, you know, your compliance officer is also your facilities manager and they may also do credentialing on the side. People wear so many hats and sometimes they're also grant writers. And it is a real problem. I want to just call out the Washington State Hospital Association. We're doing as much of this legwork in advance. So we're doing all of the procurement, identifying the vendors, negotiating the contracts, and then we are paying the vendors directly. so that the dollars don't actually hit the hospital's books. And they only need to indicate which things that they want, and then we pay for that for them.
Okay.
And just try to hit the easy button as much as possible for rural hospitals. I think as the rest, so we're only section 1.2, and the Hospital Association is section 1.3. There are, I think, 5 other sections that
Mm-hmm.
all do have grants. So I don't know how those are going to rule out and whether or not we need to hire a shared grant writer, or what to do to be able to leverage those dollars. There's only so much we could take on though at once.
Yeah. Yeah, absolutely. And so to that, the aggressive timeline, it's states had, I think, less than 6 weeks to apply. Year one funds have to be spent, I think, by September 30th, 2027. So, what is the biggest implementation risk that you see? The thing that might be keeping you up at night.
I think, the timeline is aggressive. The clock has started, but we haven't gotten the money yet.
Hmm.
I would say that we're nervous. I am nervous. And I am also reassured that we have been working tirelessly since January to line up all of the ducks so
Hmm.
that once the money comes, we could move these projects forward and spend down that money. I am a little bit more concerned, just based on what you've said, about some of the other states that they may not be as far along as us. So what happens to them if they don't meet those deadlines? And what
Hmm.
does that mean for the program? At the end of the day, yeah, I care about Washington. I care about Washington rural, but this is a federal program, and it could take a couple of states, or that could really impact the whole program. And I really hope that CMS has some grace for us in trying to roll this out under these conditions.
So, as we look forward, the program is legislative for 5 years. So, as of right now, the program, formally concludes in September of 2031, with any unspent funds needing to be returned, within the year, so by 2032. And so that creates essentially kind of a funding cliff that we're looking forward to 5 years from now. How is the Royal Collaborative thinking about that funding cliff? And what does a kind of a well planned exit from the program look like?
That's a great question. I think we were given very clear instructions by our members at the start that what we choose to invest our $5.4 million in are those projects, activities, services, infrastructure, etc., that result in a swift and sustainable return on investment. So you won't see us using these dollars to run programs that won't be sustainable in the long term.
Hmm.
And in fact, for some of these programs and activities, the ROI is so substantial that we may only pay for it for 1 year. And after that, the program will pay for itself.
That's good.
So, we were really intentional about this because, as I said, rural's been transforming for 80 years. This is 5 years. It's kind of a blip
Hmm.
in the frying pan. It's important. It's a huge opportunity. We're going to make it work as best we can, but we're planning on being here for 20 years after this we were here for 20 years before and another 20 years after. I mean, I might not be in this position. I hope not. But I think we'll see a sustainable impact.
So, what would you say to rural hospital CEOs from other states? What is the one action that they should take this month, right now,
Right now.
to position themselves well for the transformation program?
Okay, so if you're in Washington, no, so if you're out of Washington state, if you're in a rural health system and you're not part of a rural health network, they're almost in every single state, and I would try to see about joining a network because that's how you hear about everything, and it's just there's so much information, and it's nice to have it synthesized for you. It could really be your lifeline. All of the grant funding activities in Washington are, if you sign up for a newsletter, you get all of the information. So go online, like in Oregon, I think I think it's the Oregon Care Authority, and different states has a different nexus for information. It's either going to be your governor's office, your state Medicaid agency, your state Department of Health, or maybe your state social services health agency, and
Hmm.
find out, just get the information because it's coming out really, really rapidly. And finally, I don't want us to, like, each state had 6 weeks to write their application. It was not a long time at all. They did their best. But if you have big feelings about what made it into your state's application, I know they can't change it, but it's not too late to provide that feedback because this may open again. Like, there may be this was a good first try, but CMS may say, look, we really didn't do a good job. We're going to try again. And you want to get in with those folks that are writing the application, become a trusted advisor for them to make sure that they use you next time.
And there's also the opportunity to inform the state in terms of how they go about doing this the way,
Hmm.
doing the things they said they were going to do. All right. So, in 5 years, what would you hope the program brings to Washington? What would help you say that that was a success for us?
Specifically about the program, what gives me hope is that Washington did its homework. Our state agencies listened. Our tribal partners are at the table. Our hospitals are lined up, like they have signed up for things and they're just ready to start. I think this is rare, and I think it matters.
Yep.
The other thing that gives me hope is that the Rural Collaborative isn't starting from zero. We have 23 years of trust, infrastructure, shared strategy, and the Rural Health Transformation Program is an accelerant to do the work that we probably were going to do anyways. It's just all happening at once. Specifically in 5 years, 2030, 2031. So success, all 31 of the hospitals are still open, every single one. The rural communities have more access to healthcare, not less. Hospitals are getting paid fairly and on time by payers. And the peer-to-peer network is stronger, not weaker, than it is today. And if we can get to 2030 and say no rural hospital in Washington closed on our watch, and the ones we have are stronger,
Hmm.
that's the whole ball game right there. That's success.
So, where can listeners learn more about the Rural Collaborative and follow your work?
So we have a website. It's called ruralcollaborative.com, and you can sign up for our newsletter. We put out information from time to time. We're pretty small, so the website's probably the best way. We're also on LinkedIn, but I don't know how often we update that.
So, final question. What does leading fearlessly look like in rural health right now?
Leading fearlessly. Okay, leading fearlessly. I think, my opinion, right now in today's climate, leading fearlessly means telling the truth, even when the truth is unwelcome. It means saying out loud to anybody who'll listen that $50 billion not replace 137 billion. It means not hiding behind a word like transformation. It means going toe to toe with payers and not backing down just because you are small or rural or tired. It means sitting across from policymakers and saying, if one rural hospital in Washington closes, if one closes, we all fail. And actually meaning it, showing up because you're committed, not because you're comfortable, and doing the right thing when nobody's watching. And rural folks have been doing this for a long time. Nobody gets a parade. Nobody shows up for the ribbon cutting. Nobody cares what you do. You just do it. And it's what rural healthcare leaders have been doing for the last 80 years. And they don't need me to teach them to be fearless. I think they are fearless. And if I have one job, only one, I would say it's making sure that every one of the 31 hospitals in my network have what they need to get her done. And that's it. That's the whole thing.
Well, thank you, Elya. This is exactly the conversation I hoped we would have. An honest conversation about the risks and the clear opportunities, and that's grounded in the actual work of rural hospitals and the communities that they serve. So, a few things that I'm taking away from today's conversation. First, the Rural Health Transformation Program is an investment, it's not a rescue. Anyone treating these dollars as Medicaid revenue replacement is going to be disappointed and probably exposed when the funding ends. Second, the states doing this well are moving early. They're investing in capacity rather than operations, and they're refusing to treat equity as optional. Washington's 10% set aside for tribal governments is really a model worth studying for other states and really holding that line on equity. And then third, the clock is already running. So year one funds have to be spent by the end of the current fiscal year, and the entire program ends in 2031. So organizations that start planning for that funding cliff now and are thinking about sustainability of the things that they put in place will be really in a very different situation than organizations that don't. And so to our listeners, if you want to go deeper, the website links for the Rural Collaborative and the Washington Healthcare Authority will be in the show notes. And if this conversation was helpful to you, please share it with others. I'm Michealle Gady. This has been The Andromedous Way, and until next time, keep doing the fearless work to create lasting change in your communities.